Yes, ma'am. Our major audience are trainees, yes, ma'am.
Okay. And these are, I'm presuming, all from India or?
Primarily, yes, ma'am. But I'm sure people outside of India also do log in. We have a good reach outside.
Okay.
So, but yeah, our primary audience are trainees from within India.
Okay.
Yes, ma'am. Okay, so we are at 7 p.m. as of Indian time. So I think we can give it a go. Welcome everyone for today's session, our 8:39 webinar in the Ref Cafe series. It's my honor to introduce Dr. Ekta Maheshwari, who is a faculty and assistant professor at the University of Pittsburgh Medical Center. She has completed a 2-year fellowship in abdominal imaging from the University of Toronto and has a number of publications to her name. It's an honor, ma'am, to learn today from you and handing it over to you now.
Thank you. Thank you so much to the organizers of this meeting, and it's an honor to be speaking at this platform. So, without any ado here, I'll start my presentation. I'm going to talk mainly about endometrial cancer and the role of imaging. And I do not have any disclosures related to this topic here. So the aims here are, as you all know, there is a role of multiple imaging modalities: CT scan, PET scan, MRI. CT and PET are primarily used for staging purposes, but the regional evaluation is best performed with MRI, and the focus of this session is going to be MRI. So, what are the different points that we would be speaking on is recognize imaging features of typical endometrial cancer, talk something briefly about MRI protocols, identify imaging factors that impact treatment selection and risk stratification, and then talk about some pearls and pitfalls, challenges in the interpretation of MRI here. So, first question here, why do we need MRI? As you all know, the definitive treatment and the staging, which is the FIGO system of staging, is actually a surgical based staging. Surgical hysterectomy, bilateral oophorectomy, sentinel lymph node mapping, and based on that, lymphadenectomy. Traditionally, MRI has no role in the actual staging of MRI. Not all patients of endometrial cancer actually go and have an MRI. They are taken straight to surgery if it's a clear-cut surgical case. But the most important role of MRI comes for treatment selection and risk stratification of the patient on what kind of treatments um, does do they desire here. And the indications are you will have a subset of younger population who desire for fertility preservation. If there is a suspected bulky tumor with cervical involvement, to evaluate what the extrauterine disease is. An important candidacy here is non-operative candidates who are either have medical comorbidities or they just do not wish to have operative intervention. And then finally, the radiation therapy planning, either pre or post surgery, and of course, post treatment assessment. So, the role of MRI is primarily for this subset of patients for non operative interventions and for treatment planning. And in certain patients who do not undergo a sentinel lymph node mapping, the myometrial invasion assessed on MRI actually serves as the roadmap for further decision making. So, very important role in treatment planning. And the most important prognostic parameters that are evaluated on MRI are the depth of myometrial invasion, cervical stromal invasion, nodal involvement, and the extrauterine spread. So I'll just spend like a few minutes on the patient preparation, which is very important to identify those subtle findings there. When we talk about patient preparation, a lot of us face when you have motion artifacts, which can come either from bowel peristalsis, myometrial contraction, uterine peristalsis. And another important is inadequate fat suppression of the anterior abdominal wall, which results in near field artifacts and respiratory motions here. You can see the image on the left side. You're seeing this anterior abdominal wall fat pad, which has not been saturated correctly. You can look at the red arrow where you still see the fat here and see what is causing. This is causing a near field artifact here. as well as combined with the respiratory motion. And look at what is happening here. You don't see the margins of the tumor clearly. You don't see the margins of the uterus clearly. And of course, you do not see the endometrial myometrial interface. And compare and contrast this to the image on the right side, where you see this green arrow where there has been a good saturation of the anterior abdominal wall fat band. And this results in such clear images without any motion artifacts. So ideally, traditionally, people advise fasting for 4 to 6 hours, use of antiperistaltic agents. The antiperistaltic agents we use here is glucagon. Glucagon affects the bowel peristalsis, but it does not impact the uterine motions. Hyoscine is used for that, but in US it is not FDA approved, so we don't use it. But I think it is approved in certain European countries and UK, as well as in India. You can correct me there, and that can help with the uterine peristalsis and contractions. And of course, the SAT band for the anterior abdominal wall. Another important factor is when you see the initial, if you are monitoring or your techs, it needs a good education on the part of tech to recognize when they take the initial localizer or the sagittal T2 sequence for planning, and they see that the urinary bladder is significantly over distended. What does it cause? It's going to deform the adjacent organs. If you see, you won't be able to see the uterus correctly on the T2s as the sagittals. It is going to cause this phase ghosting motion artifact, especially if you look at it on the T2 and the post contrast imagings. And it's also going to displace your region of interest. This is a diffusion weighted imaging, and this is a sagittal T2 where you can see that you're unable to identify the tumoral signal here correctly. So ask the patient to wait 30 minutes prior to start of the examination. And even if you see the initial sequence demonstrating a hugely distended, it's, I think, worth it to get the patient to I know we'll have to use the localizer again once you get the patient out of the scanner to ask them to go and void. You can see that difference here when you have a incompletely distended urinary bladder. It makes imaging of the region of the interest much more optimal than you saw in the earlier image there. And another point here is vaginal gel. This is optional. It's not strictly mandated by the Society of Abdominal Radiology. But in our institute and as well as in SAR protocols, if you see, in the initial treatment, if it's like a de novo endometrial cancer, we do not use vaginal gel. Vaginal gel is used specifically if the clinicians are suspecting an inferior cervical extension of the tumor for the primary disease, or if this is a post-treatment recurrence suspected. Then vaginal gel helps in delineating this inferior extent of the tumor, coming close into the cervix there, and helps in evaluating the vaginal fornices here, but not for the primary staging. We don't use that for primary staging. Coming to the imaging planes, all of you understand that the three-plane T2 forms the mainstay, which is of the evaluation of pelvic MRI. You take the initial sagittal T2, the axial is planned perpendicular to the log axis of the tumor, and the coronal T2s are planned parallel to the long axis of the tumor. We do acquire the dual oblique axial T2 here at my institute, which is done at a few other institutes also. Not many would do that, but the dual is planned on a combination of both the sagittal and the coronal T2s, and several authors do advocate the use of a dual oblique high resolution axial T2 for evaluation of myometrial invasion here. Moving to, before I talk about the disease, I do want to spend a quick word on the normal zonal anatomy of the uterus. Important to recognize the high signal of the endometrium on T2, which you can see on both the sagittal and the axial planes, which is surrounded by the low signal intensity junctional zone, which is T2 hypointense, as you see by the yellow arrow. This is followed by the intermediate signal intensity myometrium, which continues as the cervical interstitium. And then you look at the T2 hypointense cervical stroma that continues with the junctional zone. Evaluation of this normal zonal anatomy of junctional zone and cervical stroma is very important to evaluate for myometrial invasion and cervical stromal by invasion by the tumor. Both of them are extremely important prognostic parameters for evaluation of the tumor. Coming to key signal characteristics of the endometrial cancer. T2 is the mainstay initial imaging sequence. You look at the tumor on both sagittal and the axial. So the most common signal that you see is T2 intermediate to somewhat low signal. Very rarely you would encounter a T2 iso-intense signal of the tumor, but yes, that can also happen. The tumor is hyperintense relative to this background hypointense junctional zone, as well as the cervical fibrostroma, and mildly hypointense relative to the hyperintense endometrium. So T2 intermediate signal, the gray signal, which some of us also call the evil gray signal, is always something that should be questioned. Diffusion weighted imaging adds to the diagnostic accuracy for tumor delineation for myometrial and cervical invasion, as well as if you encounter small peritoneal implants. Uh, True restricted diffusion is defined as a combination of high signal intensity on the high B value images and a hypointense signal on the corresponding ADC maps. It's always important to look at both high B value as well as ADC in conjunction. If one or the other is absent, that's not a true restricted diffusion. And then you know the high T2 and the low T2, which can be caused either by water or fluid signal or by fibrosis. And hence, always important to evaluate both of these sequences. Diffusion is particularly useful if you are dealing with a poorly delineated T2 iso-intense tumor, if there is background adenomyosis, or in select cases when you cannot administer intravenous contrast, either if the patient refuses or if the patient has advanced renal failure, where you cannot give intravenous contrast, diffusion weighted image is going to help you in conjunction with T2 signal. Coming to the post contrast imaging, we do a multiphasic at multiple 40 seconds, 90 seconds, 150 seconds, and the delayed 4 minutes after contrast administration. If you check literature, several authors have advocated the benefits of this multiphasic contrast acquisition. The enhancement of the tumor is dependent on the phase of the acquisition. If you look at the early phase, this is the leftmost image, the 40 seconds. What do you have to look for is this early subendometrial enhancement. This corresponds to the inner junctional zone, and this always enhances. It is expected to enhance earlier than the background myometrium. So you have to look for this uninterrupted signal. Whenever you see this interruption in the signal, that is indicative of a superficial myometrial invasion. When you move to the more equilibrium phase, that is about 150 seconds. Now, at this stage, you can see that the myometrium is enhancing homogeneously all around. But the tumor to the myometrium contrast is maximal at this stage, where it becomes hypointense relative to the background enhancing myometrium. This phase is leveraged for detection of deep myometrial invasion, which is the greater than 50%, as the tumor to contrast is maximal. If you look at this case, there is definitely superficial myometrial invasion, but we weren't convinced that there is a deeper or higher than 50% myometrial invasion. Coming to the delayed, the 4 minute sequence, we usually acquire all the initial phases in the sagittal plane with the more delayed phase in the axial plane. So it gives you a multiplanar post-contrast acquisition. The delayed phase is best used to evaluate for cervical stromal invasion as the cervical mucosa and the stroma enhance well. And here you can clearly see that there is disruption to the cervical stroma. In cervix, this also helps for smaller tumors and also when evaluating the eligibility for fertility preservation therapy. So this case was preemptively called a superficial myometrial invasion plus cervical stromal invasion that was then corroborated on pathologic analysis, and there was no deep myometrial invasion in this tumor. Before I move on to the details of all these prognostic parameters, I do want to touch base on FIGO. Sorry, all of you who have an interest in gynae imaging know that from FIGO 2009, the update to the next FIGO came in FIGO 2023. And it is like the role of radiology based on that FIGO from the staging purposes hasn't changed much. We were not a component of the staging system in FIGO 2009, and we are not a component of staging system in FIGO 2023. The treatment selection component remains the same for fertility preservation, extrauterine disease, and planning. But what has changed between these two is that there has been, primarily, the FIGO initially was only based on anatomical extent of the disease. But now multiple substages have been incorporated, new and prognostic groups have been defined. This update includes incorporation of histologic subtypes, tumor biology and patterns, and molecular classification. So, this knowledge for all of us is important as we talk to clinicians, we go to tumor board discussions, and this has not changed the preoperative role of the imaging modalities, but different subsets have been changed. It's beyond the scope of this discussion of mine to go over the entire each and every change and the subsets that have been evaluated. But I think it's a good read for all the trainees to go and read at this international um, I think, sorry, I think it's hidden by this bar here. This was the article here in the International Journal of Gynecologic Obstetrics in 2023. And it would be a good read to understand what are the new changes at FIGO. Some of the major changes I have highlighted here, they have incorporated a new subset 1A3. Earlier, FIGO 1 was only confined to the uterus, but there is a 1A3 which now says the endometrioid carcinomas, which are limited to the uterus and to the ovary without any capsular extension of the ovary, are also classified as 1A3. Because previously, if you saw something focally confined to ovary, that was staged as a synchronous independent tumor of ovary. But now molecular classification has now established a common clonal origin of these three, and this has been accepted by WHO, European Society, FIGO, and all of them now endorse this as stage 1A3. You do have to remember that you have to differentiate this from a contiguous spread of disease from the endometrium to the ovary, which is classified as grade stage 3. And so you know that there should not be a superficial myometrial, more than superficial myometrial invasion. There should be absence of additional metastasis, and the ovarian tumor is unilateral and limited to the ovary without any capsular invasion. You move to stage 2. There are major changes where multiple histologic subtypes have been incorporated, and I think the thought process is that the number of patients now in stage 2 will markedly increase with the new staging system than it was in the earlier one. Stage 3 again is uh, surgical confirmation of tumor that is outside the uterus. It has gone beyond the uterine serosa. It is involving either adnexa, parametrium, vagina. But one important thing that has happened is earlier, when there was peritoneal disease in the pelvis, that was classified as stage 4 in the earlier staging system. That has now been downstage to stage 3B. And the thought process behind this is that the abdominal peritoneum and the pelvic peritoneum, in terms of the tumor biology and prognosis, behave differently. And so the involvement of the abdominal peritoneum superior to the pelvis still retains in the stage 4, while the pelvic peritoneum has been downstage to stage 3. But please do read this article. It's a very good read on the clinical manifestations. Moving on to when you report an MRI, what are you looking for? But our thought process when we are reading a report should be, what is the surgeon or what is the radiation oncologist or the clinician trying to gain from a report that is going to change the management for them? What impacts the management? And if you ask the clinicians, like, give us 2 or 3 most important take home points that you want from our report, this is what you would see. Most of the surgeons and the gynecologists want to know the status of myometrial invasion. They want to know what is the extrauterine disease quantification, because there is a certain extrauterine disease which is considered as potentially resectable, which involves the nodes, the adnexa, the peritoneum. And then something that is traditionally considered non-resectable is when you have a very bulky cervical disease, involvement of vagina, involvement of parametrium. And similarly, if you ask the radiation oncologist prior to radiation treatment planning, what do they like to know? Again, the number one criteria remains myometrial invasion. Second is tumor size. They don't have a fixed tumor size cutoff criteria, but what is important for them is how bulky is the tumor transversely. Would the tumor be targetable only by vaginal brachytherapy, or would it need additional uh, external beam radiation therapy to evaluate the bulky disease? And the third thing is they want to know what the cervical stromal invasion and parametrial invasion looks like, again, for external beam radiation therapy. And I'm going to go over these important parameters which are important to the clinicians for us. Talking about depth of myometrial invasion, all of you who read endometrial cancer MRI know that myometrial invasion is the most essential and one of the most important prognostic indicator. It should be expressed as a percentage of myometrial tumor infiltration of the myometrial thickness. Either you say it's no invasion, either less than or more than 50% of myometrium. An intact myometrium is identified by an uninterrupted T2 hypointense layer of the junctional zone and uninterrupted early phase subendometrial enhancement. No or minimal is very important to diagnose because, especially, you see more and more younger patients getting afflicted by the disease and they desire fertility preservation. There are strict criteria for fertility preservation, which is then a progesterone based IUD is inserted. The candidates for IUD treatment include that you're dealing with a grade 1 disease, no evidence of myometrial or cervical stromal invasion, and no extrauterine disease or nodes on MRI. This was a 34-year-old female with a grade 1 endometrioid adenocarcinoma on pathology. And you can see this red line denotes the junctional zone, and there is no evidence of a tumoral signal beyond the junctional zone here. I do not have the diffusion weighted images here, but it is always important for a multi-parametric assessment to look at the diffusion, to look at what the tumor contrast enhancement shows, to look at what the T2 signal on both sagittal and axial shows. This patient went on to have a progesterone based IUD therapy, and you can look at this post treatment imaging. There is no residual tumor here on the post treatment images. Again, this is a second patient, 48-year-old female, grade 1 endometrioid adenocarcinoma. Initially, the patient did not wish for a surgical intervention. And so they proceeded for MRI. And you can clearly, this is like a very clear cut case. You can see this big T2 intermediate signal intensity. And as you move to the left fundal region, you see that you do not identify any significant substantial myometrium here. And you suspect that this is definitely more than 50% invasion here. And ultimately, the patient did proceed for surgical intervention, and this was confirmed on pathology. The role of what is the prognostic significance of this greater than 50% myometrial invasion? These tumors carry with them high risk of lymphovascular space invasion. They correlate with tumor grade, nodal metastasis, and higher risk of relapse. So whenever a greater than 50% myometrial invasion is reported, these patients do have concomitant radiation therapy on top of surgical intervention. Or if there is a radiation therapy prior to surgery or the patient does not desire surgery, this needs both vaginal brachytherapy as well as external beam radiation therapy for a potential LVSI suspected there. This is again a case for myometrial invasion. You can see this T2 intermediate signal on both the axial and the sagittal weighted images. Sagittal T2 weighted images, the T2 intermediate signal tumor. The green arrow depicts the preserved junctional zone that you see as a T2 hypointense signal, which you can see that here. But I don't know what's happening here anteriorly. Could this be more than 50%, less than 50%? Not sure. Again, here you do not know what's happening posteriorly and along this side anteriorly. And the white arrow depicts that you are losing the junctional zone in this region here, right? When you move to, just based on those T2 images, it we weren't very sure what's happening. Suspected greater than 50%. This is the role of multiparametric evaluation of MRI. Look at the diffusion weighted images. You are seeing a high signal here for the tumor, but then you're seeing a concomitant tumor spread to the myometrium on the right side here. And then you can see the tumor almost to the peripheral aspect of the myometrium here, high point and signal on the ADC maps there. This multi-parametric approach, we called it a greater than 50% myometrial invasion, which was later on confirmed on pathology. I think in these cases, difficult cases, where we are not sure what's happening, it's always a good idea to talk to the clinician, tell them that, because we will encounter many situations where we are not exactly sure. Many authors also advocate on the axial drawing lines where you would expect the junctional zone to be, measure the tumor, measure how much of myometrium is left. But the problem is that in the problem cases you're dealing with, which is probably a 4 millimeter, 5 millimeter region of interest, and it is not always sure. And we have to make a call either less than or more than. Good to talk to the surgeons that we think. Ideally, I think whenever we do discuss with them that we are not entirely sure, they always go with the suspected higher and treat it as like as a higher than 50%. So it's always a good idea to, I think, recognize that we may not always be sure, and there is a limitation here. And if the surgeons are aware of that, they would treat that patient, and it's going to be a multidisciplinary approach to treat that disease there. Coming to some interpretive challenges and pitfalls that you encounter when you are trying to evaluate the myometrial invasion. One of them is if the uterus has background adenomyosis, what would you do there? Look at the T2 weighted imaging here. This is a T2 intermediate signal, uh, endometrial tumor here. You can clearly see that this junctional zone is very thickened and heterogeneous, what you would see with adenomyosis. But when asked to evaluate myometrial invasion only based on this T2, not exactly sure, right? Could this tumor be going here? Is this tumor going up to this space? Not sure. But look at the diffusion weighted images are the same here. You can clearly see the high signal intensity of the endometrioid cancer, which does not propagate into the far end of the myometrium. And similarly on the post-treatment images. So importance of using multiparametric approach, diffusion weighted and post-contrast. Adenomyosis almost always leads to overestimation of myometrial invasion if you look at it only the T2 weighted images. So always evaluate in conjunction with the other sequences, because the region of the adenomyosis will enhance almost similar to the background myometrium, while the tumor is hypoenhancing relative to the background myometrium. And on the diffusion weighted images, the adenomyosis does not demonstrate true restricted diffusion. It's the tumor that will give you a high signal on the high B value and then low signal on the ADC maps. Second second circumstance, when you have multiple fibroids and then you have an endometrial cancer. Uh, some fibroids typically have T2 high point signal, but sometimes you can have an intermediate signal. So this tumor will always demonstrate restricted diffusion, almost always, while the typical leiomyomas, at least the acellular leiomyomas, will not demonstrate a restricted diffusion. In these cases, when you have multiple fibroids, the anatomy is distorted. The fibroids are compressing on the endometrium. So evaluate in conjunction with post-contrast imaging. Also, the myometrium, the fibroids mostly enhance almost similar to or less than, unless they're degenerated or infarcted, but then you would see them on the T1 and the T2 weighted also. So this is another challenging situation. Any third, this is like, in my experience, I find this to be the most challenging scenario when evaluating myometrial invasion, when you have a very expansile endometrial tumor, or when you are dealing with a postmenopausal patient, which is the case in many times, and so resultant thinned out atrophy of the myometrium. And so when you have a thin myometrium due to expansile tumor, either age-related atrophy, or if you have a tumor at the uterine cornua where the myometrium is thin to start with, what do you do? Like here in total you have maybe 2 or 3 millimeters of myometrial, and now you have to decide whether there is a 50% or more than 50% invasion in a 2 millimeter region of interest. Like, I think here, like, trying to identify that 1 millimeter is very, very tough. When I was reading this case, I was like, am I overcalling it? And I talked to the clinician that there is a 2 millimeter myometrium and the tumor is, I don't know if it is 1 millimeter or 1.5 or 0.9 millimeter. I did end up calling it as greater than 50% myometrial invasion. But yes, if you look at this diffusion weighted images here, I mean, almost makes you think that the tumor is going up to the serosa. And then here we also have to make a call on if you have a choice between undercalling or overcalling, what would you do here? Always a choice, but I think if you undercall and the patient does not get treated appropriately and the tumor comes back, especially when you're dealing with a very expansile tumor, you would prefer that, okay, we may end up overcalling and get this patient more radiation than they would ideally have given. Although with this bulky and expansile tumor, they almost always like to give radiation therapy if they're not taking the patient to surgery. But yeah, this is another challenging scenario which needs that phone call with the clinician, and this is the situation and this is what I'm doing. I've always seen the communication between the clinician and this helps us deal with those challenging scenarios on this is the reason we are doing it. So evaluate the LOI and the post-contrast imaging, especially the equilibrium phase, the 152nd phase post-contrast that helps you to evaluate the tumor and the myometrium contrast ratio. Coming to the next important prognostic parameter, cervical stromal invasion. So the involvement of cervix by the tumor can be two things. Either you have a protruding and a prolapsing endometrial tumor within the endocervical canal without any stromal invasion. And the second is you have tumor that is protruding in the cervix and is now invading the cervical stroma. And the third rare scenario is where the tumor is extrinsically from the myometrium going to the cervix without going in the endocervical canal, but still invading the cervical stroma. And why is it important? Stromal invasion is a poor prognostic parameter. It adversely impacts survival as well as the rate of recurrence. These patients will come back with higher rates of local recurrence. And how do we identify the stromal signal? We saw in the normal zonal anatomy that the cervical stroma is a fibrous component. It is very T2 hypointense, similar to the junctional zone. So anytime you see this disruption of the T2 hypointense signal of the cervical stroma, and similarly, on the post contrast delayed phase of enhancement, if you see the interruption of enhancement, that is considered as stromal invasion. You can look at this case here, the stromal signal along the right side, like almost from 5 o'clock, 4 o'clock to 9 o'clock, you have a maintained stromal T2 hypointense signal. But beyond that, look at this 9 o'clock to 3 o'clock position. You are completely losing that stromal ring here. The only where you see this maintained enhancement is between this 5 o'clock to 8 o'clock position. And this was called a cervical stromal invasion. And the patient went on to have radiation and surgery, and she still had residual tumor there in the cervix. The most important interpretive challenges and pitfalls that I just talked about is always be careful when you see an endometrioid adenocarcinoma which prolapses in the cervix. Make sure that you look at the stromal ring. Sometimes you may only have a prolapsing tumor which is widening and extending the cervical canal so much. So the intuitive thought process is that, oh, there is a large tumor in the cervix, stroma will be invaded. But if you look at the stromal signal, there was a fairly large amount of tumor in the cervix, but the stromal signal was maintained on the MRI and no stromal invasion was found on the surgical pathology. So it's very important to distinguish tumor protruding and true stromal invasion. DWI and contrast enhanced MRI help you, especially if there is coexisting cervical edema and inflammation because of the tumor here. The next step that MRI has a role is outside of the myometrium and the cervix is to look at the extent beyond the uterus, spread of the disease. Has it gone beyond the uterine serosa? Is it involving the adnexa? Is it involving the vagina and the parametrium? So whenever you see tumor involvement, this is endometrial tumor post-contrast imaging, and you can see that there was a heterogeneous signal in the ovary, what are the things that you have to look for is first, is there a contiguous extension of this tumor to the ovary? Is this a primary or secondary? Are we dealing with a synchronous ovarian primary? Or third, could that be a metastatic disease? And the things that differentiate, to keep in mind that what are the things that can differentiate the features that it is a synchronous ovarian neoplasm. If the endometrial cancer is predominantly solid, if you're dealing with a mixed solid and a cystic ovarian lesion, keep in mind that could be a synchronous primary ovarian malignancy. If you see bilateral ovarian lesions, they are more indicative that these could be metastasis. If the patient has a pre existing history of endometriosis, these are the patients who may have a primary ovarian disease. Of course, these rules don't always apply, but these are the things that can kind of lead you in the correct direction. If you raise the question that we think there may be a primary synchronous ovarian malignancy as well as an endometrium, the clinicians would, if they're not taking the patient right away to surgery, they would know that they need biopsies from different sites to figure out what's going on. And then, of course, this is another case of tumor involvement. This is a primary endometrial cancer. And when you go, you can see that there is a T2 intermediate signal. It is not contiguous with the primary endometrium here, but it was an isolated drop metastasis. But even a drop involvement of vagina is considered on FIGO if this patient is taken to surgery as stage 3 and not a metastatic involvement as in stage 4. Uh, all of us do look for lymph nodes along the retroperitoneum as well as the pelvic vessels to evaluate for nodal involvement. We know that imaging is not that superlative, especially if you're dealing with smaller lymph nodes, less than 10 millimeters, less than 8 millimeters. These large lymph nodes, you know that these are T2, intermediate signal, heterogeneous, they would restrict diffusion. These are clear-cut metastatic. But those smaller nodes, keep in mind those irregular morphology, the heterogeneous signal. If you, even if it's a small nodes, but if you see a cluster of nodes in one region, these are the ones which should raise the suspicion that these nodes may be metastatic. And the last is when you have to look for the adjacent organ involvements, especially urinary bladder and rectum. This was a case which was an extensive tumoral invasion into the bladder and had created a big vesicouterine fistula here. When we are looking at urinary bladder, the official FIGO is involvement of bladder mucosa, which ultimately needs either a cystoscopic evaluation to confirm it. But even if you see a submucosal, like if you think that, hey, this wall is involved by this, it's a good idea to mention that because we are anyways not putting a stage category there. We do not put FIGO staging in our endometrial cancer MRI reports, but involvement of bladder wall, rectal wall, lumen of these organs changes the management criteria. One important feature to distinguish here is either if it is just a bullous edema in the urinary bladder secondary to the presence of tumor, or if it is actual mucosal invasion by the tumor. The bullous edema usually is T2 hyperintense rather than the tumoral signal of T2 intermediate and low signal intensity. But if that is suspected, patient would ultimately need cystoscopy for confirmation if it's going to impact or change the management. So this is the pre-treatment evaluation. Another important role of MRI is the post-treatment evaluation, either post-surgery, if recurrence is suspected, or post-radiation therapy. So at my institute, or if you talk to gynecologists, they do not always necessarily get a post-treatment MRI unless they are suspecting something, or if they are unable to clinically evaluate the patient, or if the patient comes with intermittent spotting or something. So what do you expect from a post-treatment MRI? This is your post-surgical normal, what is expected in a post-treatment MRI. We usually give vaginal gel when we are dealing with post-treatment because it distends the vaginal cavity and helps you look at the apex of the vaginal cuff. The apex of the vaginal cuff and the vaginal vault is the most common site of local recurrence here. Ideally, you should see this smooth, low signal intensity vaginal wall on T2. You may see a fibrotic scar. This is the same features on the axial here. You see this distended vaginal lumen. You see this T2 hypointense signal where the tumor was. But when you look at the diffusion weighted images, this is a high signal on both ADC maps and the high B value images. You know, this is not true restricted diffusion. The high signal is because of the vaginal gel here, but there is no restricted diffusion, and this is a completely treated tumor here. When you come to a post-radiation MRI, what do you expect? This was what we expect in a normal pre-radiated, pre-treatment uterus, the zonal anatomy. But look at this post-radiation zonal anatomy. You see a complete loss of or the indistinctness between the endometrial and the myometrial interface and a loss of the normal zonal anatomy. The endometrium becomes thin. There is a decreased myometrial T2 signal, and then you may see some scar, or you may not always see scarring in that region. So these are the normal post-radiation, which always make it more difficult to evaluate it, because now you're losing the normal anatomy. You do not know if that is expected appearance of post-treatment. So keep these features in mind here. What are the MRI findings of local recurrence? This is a post-surgical, post-hysterectomy patient presented with vaginal bleeding a few years after the surgical procedure. And you can see that you're seeing this T2 intermediate signal. This patient did not receive vaginal gel. She couldn't hold it and she declined it. And you're seeing this T2 intermediate signal on both axial and sagittal weighted images. This is a post-contrast imaging from that region where you see this heterogeneous enhancement. And what do you do when you look at the diffusion weighted images? This is a high hyperintense signal on the high B value images, and then you see this hypointense signal on the ADC map. So you know that this is a recurrent tumor here. This patient proceeded for salvage radiation therapy, but these are your local recurrence. You would be able to appreciate the findings of local recurrence when you know what a normal post-treated pelvis is supposed to look like. So keep an eye out for that smooth wall signal. One very important finding here is we want to talk about, and especially in the irradiated pelvis, is a true recurrence versus post-radiation changes, especially if if the MRI is acquired in the initial post-treatment within 3 months of radiation therapy. You will encounter a lot of radiation-induced edema and inflammation, and you know that sometimes these things can have a similar appearance to the tumor. So keep in mind that timeline, and before calling anything strongly as that this is definitely residual or recurrent tumor, always keep in mind that post-radiation edema and inflammation can sometimes give you those similar features. And what are the important features that would differentiate? This is a patient. On the left is the pre-treatment MRI. This was the tumor. You can see a very bulky endometrial and cervical tumor extending into the parametrium. Patient had a complete radiation therapy here. Now, they recommended a MRI following radiation therapy to see what's the status of the tumor. So look at this T2 weighted images. Now you are seeing some T2 intermediate signal in the lower uterine segment here. The cervix has atrophied significantly, which is expected finding post-radiation. But you have the T2 intermediate signal. From a mental standpoint, anytime we think T2 intermediate, we start thinking something bad. But look at what's happening on the diffusion weighted images. It's not very hyper intense on the high B value images. It stays like intermediate, something similar to what your myometrium is looking here. And look at the ADC maps. There is no hypointense signal. It stays intermediate signal throughout. So this is that you have to you should not call this residual disease. You just say that this is probably related to post-radiation edema or inflammation, but because sometimes it's the patient's fear, sometimes it's the clinician's fear. I think in these cases, when you encounter something like this, it's always a good idea to call back the patient like in about 3 months for a follow-up MRI and say that we think that this is most likely post-radiation edema because we do not see anything on the diffusion, and this may just be a post-radiation inflammation or edema. But for confirmation, maybe repeat a follow-up MRI in about 3 months. Especially the more earlier you see the MRI after radiation, the higher are the chances that you would encounter these. So it is important to differentiate because the true recurrence will definitely demonstrate a low signal on the ADC maps, but the inflammation will remain high on ADC. And both recurrence as well as inflammation, they can demonstrate a mild hyperintense signal on the high B value images. So never evaluate the high B value images on its own unless and until you see tumoral signal on both high B value and ADC. Call it a post-radiation therapy changes here. Another mimicker of local recurrences. Patient has had surgery, patient has had radiation. There may be a lot of granulation tissue and scarring in that region. You see this patient here, T2 signal. What are you? The patient had some mild intermittent spotting. There is a very T2 hypointense signal here. This T2 hypointense signal is more indicative of fibrosis, scarring, granulation tissue, not like the tumor here. But there is no significant restricted diffusion here. Patient still proceeded. What are you seeing on these post-contrast images? This is your early 40 seconds, 90 seconds, 4 minutes. Look at the enhancement. There is enhancement. Is this enhancing? Yes, but the pattern of enhancement is progressive. You do not see as much enhancement on the initial. The enhancement progresses on 90 seconds. The enhancement further progresses on 4 minutes, and that is how fibrosis enhances. Gradual progressive enhancement. Biopsy reveals foci of granulation tissue, and this granulation tissue usually demonstrates a regression on 4-month, 6-month follow-up MRI. So whenever you're evaluating these post-radiation MRIs, be very careful of calling something residual disease straight away, unless, of course, you're absolutely seeing a T2 intermediate, of course, heterogeneous enhancement, or ADC low and high B value. But something which creates confusion. Keep in mind the patterns of enhancement, the T2 signal, the ADC signal, and if these do not fit in well together, if all of them are not matching each other, before calling something as residual, it's a good idea to get a repeat follow-up in 3 months, or then ask the surgeons that you need to biopsy this before confirming anything or before advocating another round of treatment for the patient. All right, so my take-home points is that recognize the imaging features of endometrial cancer on T2, diffusion-weighted imaging, the multiphasic acquisition on post-contrast imaging. Identify those imaging features that impact therapy selection for the patient, like myometrial invasion, cervical stromal invasion, parametrial involvement, extrauterine disease, and nodes, and recognize the post-treatment imaging appearances and pitfalls and the importance of a multi-parametric evaluation. For those of you who want more details, the Society of Abdominal Radiology, Uterine and Ovarian Cancer, DFP, has a lot of this information. It is a free for all website. You would see some dedicated templates if you want to do a templated reporting, which always helps the clinician, especially for the pre-treatment staging, pre-treatment MRIs. You have dedicated protocols on there, which is advocated by the Society of Abdominal Radiology. Please visit that, see if you have queries, and if you have queries and you want to email them to me, I would be happy to take any, try and answer all of them. And thank you. Thank you so much for your time and attention. Thank you so much for having me here and listening to me so patiently. And I will be happy to take any questions.